Aibowan, and a very good evening to all our viewers here on TV1. I'm Dr. Dilshan Fernando, and this is your weekly dose of wellness here on Healthline. Today, I'm absolutely honored and privileged to have one of the biggest names in gynecology and obstetrics in Sri Lanka. He is none other than Professor Dhammike Silva. He is a professor in obstetrics and gynecology at the University of Sri Jawadhanapura and also at Colombo South Teaching Hospital. A very good evening to you, sir, and thank you so much for being present here today and gracing our studios.
Thank you very much. Yes.
So today we are going to be talking about a condition which many of our ladies suffer from, especially those in the reproductive age. And this is none other than the condition of endometriosis. It's something that has quite debilitating effects in some, and I'm sure most of our viewers would benefit from this discussion because Professor Dhammike Silva is something what we call the authority on endometriosis when it comes to the Sri Lankan setup. So, sir, getting right down to the topic, first and foremost, for the understanding, I know endometriosis has been flung around in non-medical setup quite often, but most of them don't understand what it is. So, for the benefit of our viewers, what is endometriosis?
Right. Thank you very much. So, let's look at it this way. Now, if you look at the womb has a muscle and there is a cavity inside, and the cavity is lined by a cell called or lining that is called the endometrium, and these endometrial cells are the ones that get activated and then they thicken, and during the periods they come out, that is the blood that comes out, and they fall into the vagina and they come out. So, that is the menstruation, right? So, in a normal woman who does not have endometriosis, this process happens where the endometrium is only found inside the cavity of the womb. But in women with endometriosis, unfortunately, these cells are found outside the cavity. They can be found in the pelvis, they can be found on the bowel, they can be found on the bladder, they can be found inside the lining of the cavity of the tummy. They can be found anywhere. They can be even found in the eyes, sometimes in the lungs, sometimes in the area. And then what happens is during the periods, they also bleed, but they bleed where they are. And therefore, they have those effects in the places that they are bleeding.
So, that's a very comprehensive description of what endometriosis is. So, with the cyclical changes of hormones, so all these ectopic tissues also react the same way what the inner lining of the uterus.
Correct.
So, moving on with our discussions now, is there any risk factors which predispose towards this condition? What causes this endometriosis?
Well, the simplest way to answer that is we really don't know. Right? There are many theories as to how it happens. The commonest theory is that the endometrium or the cavity is connected to the inside of the tummy through the tubes. As you understand, there are two fallopian tubes that open into the cavity of the womb. This is so because the baby, when it happens or it is initially fertilized, the egg is fertilized in the fallopian tube. The baby comes down the fallopian tubes and falls into the cavity of the womb where it implants, right? However, at the same time, the womb cavity is connected to the tummy cavity through these tubes. So, invariably, almost in all women, when a woman has a period, this blood, a certain amount of blood goes through the tubes and falls into the cavity of the tummy or the pelvis most of the time. So, what happens is when this blood with the tissues fall into the cavity of the tummy or the pelvis, in most women, say 90-95% of the women, these tissues or these tissues with the endometrium does not implant, cannot implant, and the body clears it off. So, even if they fall there, still the body clears it off. So, the women do not develop endometriosis. But in a certain percentage of women, when these cells fall into the tummy cavity, what happens is they have the ability to burrow inside or to go into it. and then what happens is they implant there, and these women do not have the ability to throw it off. So therefore what happens is these women grow endometriosis outside. So grow those tissues outside. So gradually they become bigger, and then all the effects starts to come.
Right. Now, sir, with any condition, like I mentioned, there are certain risk factors, or some age or genetics, or certain other predisposing risk factors. When it comes to endometriosis, are there any such risk factors involved?
Well, generally, number one is that the biggest risk factor are the women who are menstruating. So as I told you, then women in the reproductive age can get endometriosis. That is the biggest risk factor. The second risk factor is thought that the pollution that we have in the world has changed the women's ability to clear off these cells that falls into their tummy cavity. So it is thought that pollution, or the things we eat, the things we drink, the chemicals we take in, and overall the whole environment has changed now, and therefore it is thought that endometriosis is more in the world because it is getting more and more polluted. So that is the second effect. Of course, genetics play a role. There are women who may have a genetic predisposition to endometriosis, so therefore that is also there.
As Professor Dhammike Silva described earlier, now endometriosis is this endometrial tissue being implanted elsewhere and it undergoing all these cyclical changes. Now, with these changes, what are the symptoms that these ladies would be facing with endometriosis?
So, what we have to understand endometriosis is, wherever they are implanted, they are going to give the symptoms of the place that they got implanted in. Right? That is the main thing that we need to understand. The second thing that we need to understand is, unfortunately, the awareness amongst the female population and also amongst a lot of doctors is not very well established, and therefore what happens is there is a delay in diagnosis of endometriosis. In other words, a female or a woman goes to a doctor with certain symptoms. Sometimes endometriosis is the last thing that they might think of, and therefore worldwide, this is not a phenomenon in Sri Lanka, it is a worldwide phenomenon where the delay in diagnosis is close to 8 years. So the first time a person goes, sometimes it may be just a child or somebody has just started menstruating, and then endometriosis needs to develop, because remember, endometriosis comes with menstruation, and therefore a girl starts to menstruate. Takes a few years for it to for endometriosis to establish itself, and then from there onwards the symptoms may be there, but if she goes to the doctor, they might not realize or think that it is endometriosis. So there is a large gap in the diagnosis from the onset until the time a diagnosis is made, which is about 8 years worldwide, not only in Sri Lanka, and therefore sometimes there is a delay in the treatment. So that is the problem with endometriosis actually.
And what kind of symptoms would they face?
Right, okay. So the commonest symptom is, as you would imagine, is pain. Right? So the pain is worse at the time of the periods. So the commonest symptom is painful periods. So what happens is, when there is a period, sometimes most of the women, almost 100% of the women will experience a certain amount of pain. But these women with endometriosis, what happens is they bleed from the womb and also they bleed outside the womb. So the pain is actually more, and therefore they experience very painful periods. So that is the first symptom or the most important symptom. The second thing is, so what happens is, the young girl starts to have pain, so they think it is normal and they continue thinking that pain is normal. They might take different kinds of medication. It goes on and there is a delay in the diagnosis, and by the time they come to us, the endometriosis is well advanced. So that is number one. Then they have pain before the periods, right? What happens is, because the endometriotic tissue that is outside starts to get activated and is preparing to bleed before the period, and therefore what happens is that activity and the fluid that comes out of from this causes distension and pain at the sites where they are, and the pain appears before the period. Then she starts to bleed and the pain becomes even more, that is painful periods. And then after the period also, that blood that is being everywhere else, because it has no pathway to go, the body takes time to absorb it, and therefore the pain continues after the periods. So it is pre-period pain, period pain and after period pain, which is one of the main symptoms of endometriosis. Not only that, now if you look at endometriosis, if it is endometriosis in the ovary, what happens is the blood, every time she bleeds in the ovary as well, but the blood has nowhere to go, and therefore it collects, next month it collects, next month it collects, and there is a ball of blood that is growing every period. And when there is a ball of blood inside the ovary, which is a very sensitive organ, it becomes distended and becomes extremely painful. So the pain might be worse during the period, because that is the time the blood collects inside that cyst, which we call it a cyst, or scientific term it is an endometrioma. In layman's terms, it's called a chocolate cyst. Why? Because when blood collects inside the ovary, and the blood, when it's fresh blood, is red, but when it takes time and the blood changes into a brownish material which is similar to chocolate, right? So when you cut it open, you see a chocolate material. So they are conventionally, or just in layman's terms, they are called chocolate cyst. So therefore, when a woman has chocolate cyst, it becomes extremely painful, and sometimes it is painful throughout her, not even during the bleeding itself during the periods, but in between periods also it becomes painful. Right. Do you want me to continue?
Yes,
there are lots more.
Yes, please,
right.
sir, please.
So now the other problem is, if the endometriosis is on the bowel, right, as you say, for painless defecation or to pass stools without pain, the bowel muscle or the last part, which we call the rectum, needs to be completely free. So the stools come into the bowel, then the bowel must contract and send off the stools out, right? However, with endometriosis, if it is implanted on the bowel itself, what happens is it grows on the bowel and it changes the whole bowel muscle, and therefore when it stretches with stools, when there is endometriosis on the bowel, it cannot stretch freely, and then when stools fill into the rectum, it becomes extremely painful. When she goes into the toilet and she passes stools, passing stools also is very painful, because the bowel with the endometriosis must contract to send the stools out. However, when she passes the stools, there is an instant relief. So this is a special symptom, which basically means it is called dyschezia in scientific terms, but in layman's terms it basically means just before she starts to pass stools it's painful, when she passes stools it's painful, but once she has passed stools there is instant relief. So this is a very important symptom of bowel endometriosis or large bowel endometriosis. Then comes the ureters. Now ureters are two small tubes that carry urine from the kidney to the bladder, right? These are very, very small tubes which go alongside the walls of the tummy on both sides, and these tubes are even smaller than a size of a pen or the diameter of a pen, right? So usually, because the endometriosis is mostly in the pelvis, what happens is they encircle the ureters or these small tubes that carry urine from the kidney to the bladder, and slowly they grow and they start to crush them, right? When these small tubes are crushed, the urine that comes from the kidney should pass freely into the bladder, which it does not. So what happens is, because of the obstruction, the urine starts to backflow, and then it becomes larger, and then the kidneys become larger. This is called hydroureter. Hydro is water, ureter is the tube. There is a bag-like ureter. What happens is, it gives the patient or the woman backache. So backache can be a symptom of endometriosis, and it worsens during the period. What is very, very, very dangerous is when the ureters become large, the backflow and the pressure in the kidney expands, and then the functions of the kidney shut down and the woman is going to lose the kidney. So I see many patients like that. These patients go to the urologist first, and then they discover, they do investigation, they discover that the ureter is affected, discover that the kidney is failing, and then we find out that the ureter is crushed with endometriosis. So what is very important is, if there is a woman coming with endometriosis, we need to do an ultrasound scan of the kidney, ureter and bladder to see whether it is affected. Then surgery for treatment becomes extremely important, and it needs to be done quickly. So that is how it happens in the ureter and the kidney. The next one is, if it is found on the bladder. What happens is, it can be found on the bladder wall or inside the bladder. So what happens is, the urination becomes extremely painful. Every time she urinates, because the bladder is a muscle, and if the muscle is affected with endometriosis, for a woman to pass urine, her bladder needs to contract. That is how everybody passes urine, right? So when the bladder is like a sac, so the bladder wall muscle needs to contract to pass the urine. But if the endometriosis is in the bladder wall, when it contracts, it becomes extremely painful for the woman to pass urine. So that is one symptom. Painful urination is also one symptom. Then of course, if the endometriosis is everywhere, right, then what happens is, the pain is there all the time. It doesn't disappear. It increases with periods and sometimes, and then decreases, but it's always there, which we call chronic pelvic pain. So if there's pain in the pelvis for lasting more than 6-7 months, that is chronic pelvic pain, and that is also a symptom of endometriosis. Not only that, unfortunately, if there is endometriosis on the tubes and the ovaries and everywhere, the normal functions of becoming pregnant is completely disturbed, and these women might come to us with fertility problems. So that is also something that they present with, because there is something very interesting in endometriosis. Sometimes what we see, or the amount of endometriosis that is there in the pelvis, may not completely reflect the symptoms, which means in a certain amount of women, not all, most of the women will have symptoms, but some will have a lot of endometriosis with a small amount of pain. These women come to us with fertility problem. So infertility or fertility problems is also a way women present to us. Not only that, right? So it's a long talk, right? The other thing is, the most problematic one which women come to us is painful intercourse. Why this happens is because endometriosis tends to settle down in the deepest parts of the pelvis, and they do settle down, what happens is, at the top of the vagina, right, and therefore and the tissues around the top of the vagina. Now for painless intercourse, what should happen is, the top of the vagina needs to expand without pain, because it's a muscular organ, and during intercourse it has to expand, and of course when the penis hits the end of the top of the vagina, it needs to expand freely without any restrictions. But what endometriosis does is, it sort of changes the top of the vagina, makes it hard, makes it extremely knobbly, makes it doesn't expand, and these endometriotic nodules themselves are painful. So when intercourse happens, there is very severe deep pain inside. Medically it's called dyspareunia, but it is severe painful intercourse in such a manner that women will totally avoid intercourse due to the severe pain that it causes. So all in all, these are the main symptoms, but of course there are other symptoms, like if she has endometriosis of the lungs, she will have severe pain during breathing. If there is endometriosis of the diaphragm, when it goes up and down, right, it's a muscle that divides the tummy cavity with the chest cavity, you know, there's a muscle there, large one. If there's endometriosis there, it will cause pain during breathing, right. If there's endometriosis of the eyes, of course, you will have bleeding during the period. So if there's endometriosis in the tummy button, belly button, it will bleed during the period. So those are rare instances, but those are the main ones which I spoke of.
Of course, with that lengthy and description of what the symptoms of endometriosis are, I'm sure our ladies would be little bit alarmed, but our objective is not to alarm you but to educate you and to lead you to get proper medical attention and for you to understand what these symptoms are and what it could be. So moving on with our conversation, sir, now we spoke at length about these symptoms. So if one of our females or ladies who are watching has one or more of these symptoms and they present to you, what would be your approach in diagnosing them clinically and investigations wise?
All right. Initially, of course, if the symptoms, you come to a clinical diagnosis, okay, she says these are there, so there is a possibility we come to a overall clinical diagnosis. In the sense, from the history, we can just come to a probable diagnosis that this might be endometriosis. Moving from there is the examination. Of course, if she has a very large cyst in the tummy, right, of course, when we put our hand on the tummy and we do the palpation, we will feel it. Number one. Number two, when a vaginal examination is performed, what we feel is, number one, there will be pain. There will be severe pain. Sometimes the women have very severe pain when the finger touches at the these endometriotic nodules or these painful nodules at the top of the vagina. Right. Also, the womb, the movements are extremely restricted because of the adhesions that have been caused by this endometriosis. So, when you touch the womb or push the womb, the movements will be restricted and of course, they will be painful. So, that is clinically we have to do a vaginal examination, and of course, it might be a rectal examination also because there may be endometriosis involved in the rectum as well. The next step in the diagnosis is a vaginal scan. A vaginal scan is must because we can diagnose almost every bit of endometriosis properly, sometimes better than an MRI, sometimes as well as an MRI by doing a proper transvaginal scan. It's uncomfortable, but however, that is the one that gives us the most amount of information. So, a vaginal scan will show us the chocolate cyst, the vaginal scan will show us the bowel endometriosis, the vaginal scan will show us the bladder endometriosis, the vaginal scan will show us any other deposits around the vagina, right. It will also show us the enlarged ureters if there are, or the expanded ureters. And there's something which I also forgot of that. There's a condition called adenomyosis. What adenomyosis means, it is basically, it's a different name, but it is basically endometriosis of the womb muscle. So, this endometrium, not only is it outside the womb, but if it goes into the womb muscle, it lives in the muscle, it should not be there, and it changes the womb muscle. So, it becomes extremely painful because it bleeds during the pain into that muscle. And the scan can also show us this adenomyosis, which is basically an enlarged womb with endometriosis inside the muscle. So, going from there, the next step in the diagnosis is basically we need to do an ultrasound scan of the kidney, ureter, bladder. That normally we would send to a radiologist to do it because they are the experts in those scans, and the main area that we need to check or the radiologist to check is whether the ureters and the kidneys are affected. Going on from there, once we do that scan as well, the next step in the management is MRI. Now, MRI is done usually to look at endometriosis of the nerves, because I forgot to tell you one of the symptoms is if we find endometriosis around the nerves of the pelvis. There are large nerves that are there in the pelvis, and what happens is if they encircle these nerves, large nerves, the woman will have severe pain going down her legs. Usually it is on the upper thigh and the knee, or going, if the sciatic or the large nerve is involved, that is the largest nerve in the body, the pain will go behind her thigh right down to her feet. And if there is endometriosis of the nerves, a scan will not see that. So, we need to do a special MRI just looking for the endometriosis of the nerves if she has symptoms of which I spoke about. So, that will complete our complete investigation as to the extent of endometriosis that there is in the woman first. So, therefore, we have a comprehensive diagnosis, as to where the endometriosis is, what organs are involved, what are the sizes of the lesions that are there, whether they are involved in the nerves, bladder, bowel, ureter, peritoneum or anything else. So that in the end, after all this, starting from the simplest of the history, starting from the tummy, ending with the MRI, we have a comprehensive diagnosis and workup as to exactly where the endometriosis is and what the sizes are and what it's doing to the body. So that is how we complete the workup.
So that is very informative description of how a workup is done in a patient with endometriosis, even though some of you may not have far-reaching symptoms. As Prof. Dhammike very correctly went on to explain, it is a very far-reaching condition which can affect almost any part, especially in your pelvis. So you definitely need to be followed up by a properly qualified medical practitioner, and this comprehensive workup needs to be done because like Prof. Dhammike Silva said, it can have so many effects within yourself and it needs to be found out and properly treated, and better sooner than later. Now, which brings me to the question, sir, now with all these far-reaching effects, what would be the treatment modalities? There may be medical and surgical, but how do we go about to treat all these?
Right. Number one, endometriosis is not cancer, right? It's not a malignancy. However, endometriosis behaves like a cancer because it invades and therefore it will give its symptoms. What is very important is we approach treatment based on two things. One is whether she requires fertility or whether she does not require fertility, whether she is hoping to become pregnant or whether she is not hoping to become pregnant. The second part is there are women who do not require fertility. That means they may be having children already and the family is complete. So these type of women are coming to you with symptoms of pain or with organ dysfunction because it is affecting the other organs, right? And the third type of women who come to you are the women who do not have symptoms, but it's an incidental finding on a scan because they go to some other specialty, they do the scan and suddenly find something and they send you. And of course, there's a fourth one, the ones that go to other specialties and they find out suddenly, especially the urologists, and they find that the ureters are involved, there is the ureter is expanded, the kidney is expanded, or there is kidney failure. So those are the other kind of women that will come to you. So now the treatment modalities will change depending on two things. Number one, I said whether they need fertility and whether they do not require fertility. The main, and of course if the kidneys are affected, they need urgent surgery. You cannot have medical treatment. Now the mainstay of or the understanding of endometriosis, if the woman does not have symptoms, number one, if it is not affecting any of her vital organs and having problems with function, number two. Number three, if her quality of life has not changed or there is no change. Now quality of life means 5-6 things. Whether she can go about a professional work, whether she can go about a day-to-day work, whether she can go about a normal social sort of life, whether her sexual life is normal, and whether her psychologically, whether she has depression because of this. If none of these are affected, basically you don't need to treat the woman, right? So if no symptoms, no organ dysfunction that endangers her, if her quality of life is not affected, we can just leave her alone by just doing a follow-up. For example, if we find 3 centimeter chocolate cyst in a woman, she has no symptoms, but it was discovered when a scan was done, she comes to us. Then of course, after taking a comprehensive history, if there is no change in the quality of life, you just leave it alone. You can just maybe look at it again or revisit the whole problem in about 6 months time or 1 year. You can just follow it up, or if she becomes symptomatic, she can come back to us. That is one kind of patient who are, it's good that we don't need to intervene. The second kind are the women who do not have fertility wishes, but may be having mild symptoms of pain with not much organ dysfunction. These women can be managed medically. So, we can give them medication, pain relief if there is a mild amount of pain. There may be women who will require hormonal treatment, because endometriosis is driven by ovarian hormones, hormones that are produced by the ovary, and these hormones are extremely powerful, and especially it's driven by estrogen. Yes. And these hormones are the own woman's hormones are extremely powerful. So, what we try to do is to try and suppress these ovarian hormones. However, women needs hormones for all her bodily functions. The heart needs hormone, the skin needs hormone, the lungs needs hormone, the breast needs hormone, the brain needs hormone, everything. And therefore, what we try to do is we give her, commonly what we do is we give her oral contraceptive pills, because they are the cheapest hormones available, and they contain very low doses of estrogen and progesterone. So, what happens is the ovaries get suppressed, and we give the minimum amount of hormones for the other bodily functions. So, therefore, the endometriosis remains slightly less active or quite less active, right, as opposed to being active by her own hormones, because the ovaries are not active now, and therefore, the endometriosis can be controlled and she can live her life without it. So, that is one option which we use. Of course, there are other hormonal, we can give injections to suppress it, right. Then we can give local hormones by putting in a special device which is called a levonorgestrel releasing intrauterine device, which releases hormones inside the womb, and that is specially good for adenomyosis or endometriosis of the muscle of the womb. So, these are the hormonal treatments that we can use for women who do not have fertility, because when you give hormones or hormonal suppression, the ovary shut down. So, egg is not produced, so she can't have babies. So, we cannot give any hormones for women who want children, right. Then comes the next category, women who requires fertility. For that women, we can initially try pain relief, and we can try other types of fertility treatment. However, if that does not work, then the next step in the management is surgery. And I need to emphasize, I need to say that surgery, if done, must never be done by a laparotomy. It has to be by a laparoscopy. It has to be minimal access. If you do a laparotomy for endometriosis, that's a crime. Nowhere in the world, in any centers of the world, you will be considered a very inadequate, inept person or gynecologist if you do endometriosis by doing a laparotomy. So, you should never go for a open surgery for laparotomy. The reason is, number one, the evidence. Evidence says laparotomy should not be done for endometriosis, number one. Number two, evidence says the best job which you can do for endometriosis is by laparoscopy. The third reason is endometriosis is very small tissues deep inside the pelvis. You open a patient up, you cannot see all that. In laparoscopy, the approach is from the sides, number one. Number two, you expand the tummy with a lot of gas, and therefore, everything becomes clear on a screen. Number four, everything is blown up, or it's expanded 10 to 15 times, right. It's because it's a telescope that is put inside, and the picture becomes 10 to 15 times larger, and therefore, we can see the smallest nerves, the smallest organs, the tissues, everything we can see clearly, and therefore, if it is surgical, it has to be laparoscopy. So, now getting back to our original discussion, the principle is for women who requires fertility, and if the initial treatment has failed, then of course, it has to be a laparoscopic surgery. And the principle behind laparoscopic surgery is remove as much endometriotic tissue as it is possible, right. Maximum removal or excision of endometriotic tissue. Basically, if there is bladder endometriosis, you cut that piece or shave that piece off and resuture the bladder. If there is endometriosis of the bowel, either you shave it off, either you cut it off and resuture the bowel. If the segment is large, you cut the whole bowel and join them. Okay. If it is the ovary, then of course we have to, if there is a cyst, we have to cut it open and remove the thing and remove the lining. In some women, this removal of the lining may not be indicated, because if they are exclusively, if they do not have much symptoms, but if the fertility wishes are the most important, sometimes you can just drain it, take the eggs for fertility like IVF and so that. So, case by case we need to decide whether surgery is necessary. If there is the ureters are involved and there is hydroureter and hydronephrosis, 100% before she loses a kidney, you need to do the surgery, because that is very common. Even few days ago I did a surgery like that. I mean, so all these surgeries we might need to, in that case, either we cut off the segment that is affected and join it end to end, or we need to cut it off, remove the part that is removed, and then take the ureter up, dissect it and put it back onto the bladder in a new place, which is called reimplantation. So that is how we treat the ureteric endometriosis. Then of course, if there is endometriosis on the top of the vagina and not on the tissues, we need to clear everything. We need to clear, excise, and then clear as much as possible. What must be understood is endometriosis cannot be cured. It is a chronic disease because there are cells everywhere which are activated by her own hormones. So therefore, and all the cells cannot be removed and the organs cannot be removed, and therefore there will always be microscopic deposits which will get activated over time. So we cannot cure it, we can control it, and we can make the woman's life far better than what she has now. Right.
So that is one of the most comprehensive and very well understood descriptions about the treatment modalities for endometriosis that I have ever heard in my lifetime. I am sure you, our viewers, would greatly benefit from this kind of explanation. Of course, this is not to lead you to just understand and sort out your own treatment, but to encourage you to understand, educate and get followed up by a properly qualified medical practitioner. Now, sir, as you said, there is a certain amount of delay in properly diagnosing endometriosis, and there is a certain amount of reluctance in patients also when it comes to gynecological matters, sometimes which deter them from seeking treatment. If a person doesn't get the timely treatment, what could be the possible complications?
Well, the complications are that every time she has her period, the symptoms are going to get worse and worse. The biggest complications are, if the ureter is involved, she can lose a kidney. If the bowel is involved, she can end up with bowel obstruction, which may be life threatening, right? But the main problem is, most of the time, is pain. I do not touch on one thing. If she has no fertility wishes, one of the main things which we do, because if she has adenomyosis, because adenomyosis is very commonly associated with endometriosis, one of the things we do is to remove the womb, which gives an immense amount of relief. So that is something that we need to, because actually if there are no fertility issues, right, the treatment becomes a bit more easier, because you can remove the womb, you can excise everything that you need to, remove all the endometriosis that you can, then afterwards you can suppress them for a long time with hormones, which we cannot do when she requires fertility. So in fertility, if she requires surgery, maximum excision, and then you have to go on for her fertility treatment. What happens with fertility treatment is that her own ovaries need to work, because she needs to put out eggs. However, when that happens, her own hormones will start to again stimulate whatever the endometriosis that is left, and again in 6 to 8 months, maybe 1 year, if she does not get pregnant, it's a race against time, then she will regrow all her endometriosis. That is the sadness of this disease.
So, if a patient with endometriosis ultimately does become pregnant, sir, does it cause any complications during the pregnancy?
Not really, unless she has a ureteric obstruction, right, and that will become more. However, if she gets pregnant, what happens is the predominant hormone in pregnancy is something called progesterone. The estrogen comes down, and therefore it suppresses the endometriosis that is there, and normally the pregnancy will be uneventful. At the same time, once she delivers, but she will be breastfeeding for some time, so the suppression will be there for some time. But afterwards, when the hormone starts to work again the endometriosis will regrow.
With that and with the time constraints that we have, we are coming towards the end of this program. But before we wind up, sir, what would be your message to these number of females who are suffering in this condition and their families? What would be your closing statement and take-home message for them?
Right. Especially for younger women, if they have these symptoms, especially very painful periods, pain before and after, or any of the symptoms which I spoke about, it would be better if they seek medical treatment, or at least get themselves an ultrasound scan that can diagnose problems initially, and then we can initiate treatment so that it does not get complicated with time. And the other message I wanted, everything is manageable and it needs to be managed expertly, and therefore women need not suffer in silence at home. It can be managed and we can make their lives far better.
Definitely. As we discussed, endometriosis has many manifestations. It's a far-reaching condition, but like Professor Dhammike Silva says, it's manageable, controllable, and with the development of medicine and technology, there are so many various options that can be offered to you. So, as we say on Healthline time and time again, do not suffer at home in silence. Everything has some sort of a solution in medicine, so make sure that you educate yourself, your family, and seek the treatment of a properly qualified medical practitioner. And I believe today we had a very in-depth conversation about this very common condition, endometriosis. I'm sure most of our viewers benefited greatly from it, and therefore I thank Professor Dhammike Silva very much. Thank you very much, sir. I know how busy you are in your schedule.
Thank you for inviting me.
So it was a great honor and privilege for me, myself personally, and on behalf of the TV1 crew and our management, I thank you very much for gracing our studios this evening. And with that, it is time to wind up from this edition of Healthline. Until I meet you again next week with your weekly dose of wellness, this is me, Dr. Dilshan Fernando, signing off, wishing all our viewers Aibowan.